permanently. No.
So this is a short history of the patient. It's a 41 years old male. He complains of voiding LUTs for last 25 years, which was aggravated more in the last 2 years. There was poor flow, thin stream, prolonged micturition, no hesitancy, no storage LUTs, no hematuria, and occasional febrile UTIs.
Any history of dysuria?
Yes.
Okay. History of urethral discharge?
No.
Patient is having any past history of any endourological intervention or any history?
Yes, in the
Any
subsequent
surgical intervention?
not exactly surgical intervention. He had undergone evaluation and a minor procedure he has undergone. In the next slide, we'll be elaborating on that.
Go to the next slide.
Okay. Circumcision at the age of 15 years.
This patient underwent circumcision at the age of 15 for some voiding symptoms. The documents of this particular procedure is not available. In 2004, he underwent myotoplasty and cystourethroplasty, and the document reveals BXO plus stenosed meatus, myotoplasty done, scope passed, and the entire length of the urethra up to membranous region is stenosed, stricture dilated up to 18 French, ureteric orifices normal, bladder trabeculated. And after that, he was diagnosed of panurethral stricture plus BSO. Till now, he was on urethral dilatation until 2 years back when he developed a near retention. He refused for SPC and hence he was catheterized with the feeding tube.
So, after when he was, the patient is on a feeding tube or like he's still on dilatation.
Patient voids with difficulty.
But he is not currently on any periurethral or suprapubic catheterization.
No.
Okay. General examination.
The history on what can happen with long-standing stricture? This is for how many years?
Ma'am, since 2004, patient is 18 years. Patient is having a long-standing stricture.
Long-standing stricture in which we not treated.
Ma'am, any history of only in 2020 years.
Tell me what are complications of long-standing stricture?
Ma'am, it may lead to retention or stone formation, or he has a epididymo of recurrent UTI. Malignancy, if it is a secondary to lichen, if because patient is also has a BXO in 2004. So, our patient may presented in a renal failure, acute kidney injury.
Why you jumping to general exam? You have to ask all these things. He has history of febrile UTIs and whether there was
hepatitis.
Whether he has plandury, whether he has hematuria,
whether no hematuria patient.
Any symptoms of CRF.
Any history of patient with a urethral discharge or any scrotal? No, ma'am.
Then?
Or any.
What else can you ask in relation to patient with
Ma'am, difficulty in.
Something which is not.
Sunita, we can't hear you.
Sir, I was asking him what else history he wants because he jumped to general examination. So then he answered as to what will be the complications of a long-standing stricture. And now I asked him, what else will you ask in relation to the penis in a patient with BXO?
Even your answers are not audible, man. Azad?
Sir, I will ask for the
What happens to the penis, man, in BXO is what madam wants to know. You have seen, no?
Yes, sir.
What happens?
Well, what is the difference between, anybody can answer, difference between an acute phase of BXO and chronic BXO? What happens to the glands? Does it remain the same size, shape? Does it get deformed? It gets deformed, right? And how do you differentiate between acute and chronic on history?
Any episodes of a fever if the patient
Fever doesn't come. It's a local sign or local symptom.
coolness of the penis in the
Redness or development of red patches, itching, and this can be seen in the acute phase. Okay, on general examination, everything seems normal, circumscribed, dry, scarred glands.
The fever is due to the urinary infection. It is not due to this.
BXO.
In fact, the onset of BXO is very insidious. There may be some mild, low grade, some patient may not have any idea at all, because invariably it is after the circumcision in many of these patients.
Anything else you want to ask him about what he has told you?
What else can happen to the penis in patients with BXO?
the malignancy may happen.
When the glans is scarred, in the acute phase, the glans is reddened, edematous. But in the chronic phase, it gets scarred. And the scarring of the penis caused to the glans.
So it reduces in size and sensation is lost.
Sensation will get
The size can be big size, everything can be there. But it causes something else if the glans is scarred.
So vascularity reduces.
No, it produces contracture, no, it produces caudy. So some of these patients can have a glans caudy.
And this, has he told you all the findings? Would you like to know something more?
Anything missing in the general examination of genitalia? Has he told you the color of the glands? Of the surrounding corona and if at all any prepuce is remaining? So then you have to ask him, right? Can you imagine with what he has told you, can you imagine how the penis looks? No. So ask him.
What is the color of the glands and what is the about the coronal sulcus and any preputial skin is there or not?
The glans is scarred, it is whitish in color.
Okay.
And the patient was circumcised earlier.
Okay.
The meatus is at the coronal region because previously he has undergone meatoplasty.
What about the penile skin and the surrounding skin region?
That is normal.
Normal.
The rest of the penile skin is normal.
Any images of that clinical imaging?
No images.
Ma'am, I will do urine routine microscopy of the patient. What is the serum creatinine of the patient? 0.92. Urine routine microscopy, I want to know. Ma'am, I will do imaging with retrograde urethropography and micturating cystourethrogram. What is RGU? I want retrograde urethrogram and micturating cystourethrogram if done.
What is the problem in doing an RG in such a patient?
Sir, one,
What could be the problem in doing an RGU in such a patient?
sir, meatal stenosis, one problem, sir.
Okay, so
What is the problem in relation to metal stenosis?
We may not be able to do the RGU properly, may not be able to put the catheter for RGU.
what can happen?
Cannula, bro. Okay. We have to use a cannula or small feeding tube to do RGU.
You have to use a cannula, okay? Then what can happen? What can be the consequence of RGUs in patients with BXO?
Sir, there's a long, in case of a BXO, there's a high chance of long stricture. It may, if we do the RGU with the pressure, the mucosa may get break, and there's the extravasation of a contrast, sir, in the corpus.
Is it extravasation or something more dangerous?
Sir, sir, contrast may from there go into the taken up by the vessels, and that may cause problems, sir.
So what is that called? That is not called extravasation. The contrast enters what? What is the contrast enter? And why does this happen?
Sir, because of the if we do with the high pressure, that mucosa may break, and from there go to the corpus conjunctum and go to the vascular and taken up by the vessels, sir.
So that is intravasation.
Yes. Okay.
Intravasation into the corporal vessels, corporal veins, dorsal vein, and then into the pelvic system, pelvic venous system. It can go right up to there. All right.
Yes, sir.
It can go right up into the pelvic veins, and as a result of which, what can happen?
Sir, patient may have sepsis also.
Yes. Yes. What is the other classical finding on the RGU in a patient with BXO?
Sir, pan-urethral stricture we get in
Okay.
sawtooth
You may get, you may not get. What other findings are you seeing in the RGU? We talked about intravasation, then you talked about long centipede stricture.
Sir,
Can you get any other findings?
sir, inflammation of the Litters gland, so that
Literitis. Yes.
Literitis.
Anything else? Non-distensibility of the anterior urethra. Non-distensibility. All right?
Okay, sir.
Fixity and rigidity of the urethra as a result of the fibrosis and inflammation. So, what is the normal caliber of the anterior urethra?
Sir, it vary from, sir, in anterior urethra fossa, if it start from the, sir, EUM, it is usually 24 French. And while in the penile urethra it is 26, and in the bulbar urethra it is 36 French, sir.
36 in the bulbar.
Yes, sir. 32 plus 32.
Huh? इससे बताओ यार.
36 is a bit.
Normal anterior urethra is 24 French, which is about 8 millimeters. The meatus is narrower. Meatus has to be a little narrower. Okay, so that you get a stream. But it can't be an inflamed meatus. An inflamed narrow meatus will not be there. You can have a meatus which may not be accommodative to a 24 French catheter or a dilator, but the anterior urethra will be. Alright?
Yes,
So
sir.
that is why you have certain times some patients with a meatus that does not allow you to put the scope, you have to do an otis urethrotomy. It's not that the meatus is fault. It's just that the meatus is a little narrow in most situations. Alright?
Yes, sir.
But not narrow enough to cause obstructive voiding.
Next
What
slide.
else what can you get on the MCU?
Sir, if the patient is having this long segment stricture and that is of since more years, sir, bladder may be trabeculated or diverticulum, we can see, sir, irregular outline of the bladder on MCU, and uh, reflux may be there.
Okay. Can you get stones?
Yes, sir.
Have you seen the patient with bladder with BXO and stones? Have you seen a patient primarily BXO and vesical calculus? Unlike in a patient with BPH and vesical calculus. Have you seen?
No, sir.
Huh? These are strange things, no? Here's a patient who got obstructed voiding and he does not have vesical calculus, whereas the fellow with BPH, he does not have such a long history and he's got vesical calculus. Huh? Is it more common? You look through your records, you will find how many times you have to do lithotripsy for a patient with primary BXO. I'm not talking if somebody's got an SPC. As a result of the SPC has got a stone. Primarily stone. In the bladder, not kidney stone dropped into the bladder, primary bladder stone. Huh?
Okay.
Long history, BXO fellows. Very strange disease, you know. Very strange disease. They go on for so many years. How many patients have we seen with renal failure in BXO? Huh? Again, a very strange phenomenon, isn't it? These guys are obstructed, so-called obstructed voiding for so many years. Yeah. You get the odd fellow. You get the odd person. It's not something. We'll be seeing so much more of renal failure if we consider the number of BXOs we've seen. For some reason, these guys are able to empty their bladders. And the reason why they go into retention or something like that is because somebody has tampered with the urethra. Invariably, somebody has done something, not knowing that he's got a stricture there, BXO, not looked at it, and tried to instrument him, create a false passage, create a trauma, and that produces retention of urine. You ask all these fellows, they'll tell you that. So it's a very strange disease, this BXO. The more you begin to think about it, the more you begin to wonder as to what is it that, why is there another form of treating it? Anyway, so what did you do for this fellow? What do you want to do for him? Show him the MCU.
Previous slide.
RGU, show the RGU. What would you call this type of disease?
So the panurethral stricture.
Right.
Anything you would want to comment on this RGU?
Multiple strictures are there with small urethra is not extensible, irregular in outline, but the contrast irregular in outline.
Talking to the mic.
Multiple irregular strictures are present throughout the anterior urethra. It is non-distensible, irregular outline with there's the extravasation of contrast also present.
Where is the extravasation?
Not extravasation, this corpus. This corpus gland is corpus gland is visualized, ma'am.
What has happened to the bulbar curve?
Loss of bulbar curve is there. Loss of bulbar curve.
Straightening of the urethra, loss of the non-distensible. At the same time, that which is this cannula used? What is the name of this cannula? What is the size of its tip?
It is 8 cent tip with
What is the name of this cannula? Yes, on that side. Name of this cannula.
What is the name of this cannula?
Allowing that cannula to go inside, right? That meatus is allowing. What is the name? Starts with R. Routers. So what? Why is the posterior urethra you saw in the next film? Next film, can you show the next film, please?
Next slide. Ma'am asked about this. You said something about Cowper's gland. Eh?
Yes, sir.
Where is this Cowper's gland situated?
Sir, they are present in the membranous urethra.
You mean inside the urethra, the gland?
Is it inside the urethra?
They are present in the membranous urethra.
Corpus gland.
They are present inside the membranous urethra. Huh?
Along the urethra, they are present, sir.
Along the urethra, whole length of urethra.
No, sir, they in the membranous, but they are duct open into the bulbar urethra.
So where is this gland situated?
Where is it situated?
Posterior.
Inside the spongiosa, outside the spongiosa, in the muscles. Where is it?
Spongiosa.
No, you mentioned Cowper's gland. That's why I'm asking you. You're right about the duct. The duct opens into the bulbar urethra, but the gland, how many glands are there? 1, 2, 4, 6, 8. How many glands are there? Arey Baba, 2 glands and 2 ducts. And they are situated between the 2 layers of the urogenital diaphragm. Okay. A very small little gland between the 2 layers of the urogenital diaphragm. It's got a superior and inferior component, isn't it? And in that it is situated. You look at Gray's Anatomy and all that, they will tell you that. So see the voiding study. See the voiding X-ray.
Posterior urethra is dilated and bladder irregular.
What has happened? Entire urethra is dilated. Posterior urethra entirely dilated. Any other finding?
Ma'am, prostatic and membranous urethra.
I'm talking of the prostatic urethra or the posterior urethra, not membranous urethra. Anything at the bladder neck? See the bladder.
What is that phenomenon called there in the bladder neck when there's a distal obstruction? You see it in posturethral valve, you see it in stricture urethra. Huh? What is that radiological finding? Have you heard of this word shouldering?
Shouldering.
Yeah, this is called shouldering of the bladder neck. Classical. You see it classically in posturethral valve, but you see it here also in patients with stricture and all the rest of it. Okay? Because of a secondary hypertrophy of the bladder neck, you get this. And that is why there are some patients after urethral stricture surgery in BXO or stricture surgery, the urethra is patent, but the flow is still not very good because they have a secondary bladder neck hypertrophy and that causes obstruction. And that is why some of these patients benefit with Urimax or a bladder neck incision. But you have to prove that the urethra is patent, but they are still obstructed. Okay? So what will you do for this guy?
Sir, I will do two-stage urethroplasty for this patient, sir.
What is the complication of two-stage urethroplasty?
Patient may again have, sir, recurrent stricture patient may develop
Where?
at the, sir, at the proximal,
The stage urethroplasty has got a first stage and the second stage, isn't it?
yes, sir.
Now the question is asked, what is the complication of the two-stage urethroplasty? Each stage has got its own complication. So what's the complication of the first stage?
Sir, stenosis of the proximal, new UMB created proximal.
All right. What's the other complication? Any other complication? Something that Turner mentioned many years ago, and he said that you need to look out for this and electively call the patient back to make sure it doesn't happen. You heard of Turner, no?
Yes, sir.
Yes. See, laying open the urethra can cause cicatrization due to exposure and drying. Number one. Number two, it can cause synechia formation. So what happens is, because you open the urethra and left it, the urethral mucosa, the scrotal folds, depending on how you do this operation, they can join together and there will be synechia formation. So electively, you are expected within 6 weeks to actually call the patient back and run a dilator or your hand right across the urethra to break the synechia. And you do this periodically. So you tell the patient also to do this so that you don't have this, especially if you bivalve the scrotum and he's got two testicles hanging like goats, then there's a great chance of this sticking back again. So electively, you tell the patient to put a wet gauze or a petrolatum soaked gauze between the two leaves so that it doesn't join up till all the healing occurs. It's in the early stages of this that it happens. Once healing has occurred, then it's okay. So that's why at 6 weeks, electively you have to do it so that it heals and this thing doesn't stick. Unfortunately, sometimes it can occur even later. So this is one of those complications of a stage urethroplasty, the first stage.
Sir, I think there is a paper also by Mandi about
There are papers, yes.
exposure of the urethra in Arab countries and in
Yes,
UK,
yes.
I think.
Urethral exposure, so that's the problem. So that is why many people don't put a buccal mucosal graft and leave it in the first stage because it dries up. It can dry up and it causes a problem. So you want to lay it open, and the second stage you put an inlay BMG and close it at the same time so that the urethra, the buccal mucosa, which is used to be moist. The buccal mucosa has to be moist all the time. If you leave it exposed, it gets dry.
So how can you keep it moist? What will you tell the patient? How to keep it moist? Huh? Coconut oil. What else?
Some emollient. Okay. Very safe. So they have to apply it and keep it moist so that it does not dry, cicatrize. It's a real
Also,
problem.
roll of tacrolimus and steroid creams and
Yes. All
in
these things
application.
are useful in these patients.
Yeah.
That's why we told that fellow, this guy upstairs, to apply clobetasol at the meatus because basically it's BXO, the skin will have BXO, to apply clobetasol and keep his meatus calibrated. All right?
Yeah. What is the percentage of tacrolimus? Huh? 0.1.
There are 2 or 3 strengths available. 0.1, 0.03 is the ophthalmic one. 0.1 is what you can use. And each of these has got a cost to it also. And 0.5 also. So all these are there. You can use any of them.
Yes.
Clobetasol is the other one, which is marketed as Tenovate. So all these can be used.
Okay, sir.
Right. Thank you.
Thank you, sir.
Thank you, ma'am.
Thank you.
How is the garden going?